Hello there. My name is Srivastava. I'm one of the neurologists at Boston Children's Hospital focused on neurogenetics and neurodevelopmental disorders. I'm going to talk about a really interesting topic, which is the genetic workup of neurodevelopmental disorders. Genetics has come a really long way, and we have some powerful tools for discovery that will likely change how all of us practice medicine. My learning objectives are simple. Number one, appreciate the importance of etiology in neurodevelopmental disorders. Number two, understand the basic genetic workup of neurodevelopmental disorders. And number three, learn about the role of new technologies, especially whole exome sequencing, in diagnosing genetic causes of neurodevelopmental disorders. I have no conflicts of interest to disclose. Here is an outline of my talk. I'm going to divide my talk into two parts, which I'll call the pre-exome sequencing era and the post-exome sequencing era. For the first part, I'll provide some context, review some background on neurodevelopmental disorders and genetic testing, discuss a framework for evaluating different neurodevelopmental disorders in the pre-exome era. For the second part, I'll talk about a technology called whole exome sequencing used in this population, discuss how the work of NDD has changed with the use of this technology, and wrap things up with a clinical case and closing thoughts. So let's get right to it. First, some context. As you know, neurodevelopmental disorders are disorders that affect various aspects of a child's functioning, resulting in a spectrum of clinical descriptions like cerebral palsy, autism spectrum disorder, intellectual disability, and so on. The problem with clinical descriptions is that they don't tell us about what causes them. In some cases, environment may play a role. In others, there may be a genetic factor, and our goal is to find out those genetic causes with the hope that we can do something about it. Why is a diagnosis important? There are several reasons. Establishing a genetic diagnosis allows proper counseling on recurrence risk of that disorder. It puts families in contact with other families who are similarly affected, and sometimes gives them a sense of relief knowing they finally have a diagnosis. It provides more appropriate expectations for the future, and perhaps most importantly, it can change medical management and open the possibility for treatments specific to that disorder. Before diving in, let me review some basics on neurodevelopmental disorders and genetic testing. For the sake of this talk, when I use the term neurodevelopmental disorders, I'm really referring to intellectual disability, autism spectrum disorder, and cerebral palsy. Let me clarify a few things about global delay in intellectual disability. Strictly speaking, global delay is significant developmental delay, meaning a developmental quotient less than 70% in at least two major developmental domains. I usually think of global delay as the precursor diagnosis to intellectual disability. That's because around age 5 or 6 or so is when the label of global delay is no longer applicable and the term ID is used. And that's because around this time is when kids can undergo formal neuropsychological testing, which can generate a full-scale IQ. ID is defined as having significant impairments in cognition, meaning a cognitive developmental quotient less than 70% or a full-scale IQ less than 70, along with impaired adaptive skills with onset before age 18. Autism spectrum disorder is defined as having significant impairments in social communication, as well as at least 2 out of these 4 impairments in at least 2 out of these 4 restrictive repetitive domains. Cerebral palsy is a static motor encephalopathy, resulting in deficits in tone, movement, posture, reflexes, so on, impairing gross motor and fine motor functioning. The truth is, there's significant overlap between neurodevelopmental disorders. 40% of children with autism have ID, 50% of children with cerebral palsy have intellectual disability. Keep this in mind when we talk about workup. So let's talk a little bit more about genetics. As you know, most cells in our body contain 23 pairs of chromosomes, which are long strands of DNA organized into genes, which encode proteins, which carry out different functions. Our genome is a set of 3 billion DNA base pairs contained in these chromosomes, accounting for over 20 to 30,000 different genes. Our genome can contain lots of misspellings or even paragraphs that are missing or duplicated. Usually it's okay, but in some cases it's not, and the result can be a genetic disorder. There are different ways of testing for anomalies in the genetic code. Biochemical tests involve changes in levels of chemicals in cells resulting from defective enzymes and other proteins. Cytogenetic tests involve investigating changes at the chromosomal level. DNA tests involve changes at the DNA level. I won't go into specifics about biochemical testing, but I will talk about cytogenetic testing and then DNA test. One of the earliest cytogenetic tests was karyotype, which can detect aneuploidy, rearrangements, translocations, and large deletions or duplications over 5 to 10 million base pairs. The yield of a karyotype, excluding Down syndrome, is about 3%. FISH stands for fluorescence in situ hybridization and is a later technology involving probes that target known microdeletion regions and subtelomeric regions. Chromosomal microarray has a much higher resolution, as small as 20,000 base pairs. There are different kinds of microarrays, and SNP array is one of them. A microarray uses the binding of probes to assess for copy number variants, which are deletions or duplications of chromosomal material. Probes are DNA fragments representing precise chromosomal locations. These are arranged on a chip in an orderly way. Its diagnostic yield is about 15 to 20% of patients with global delay, intellectual disability, autism spectrum disorder, major congenital anomalies. A chromosomal microarray will be able to detect copy number variants and loss of heterozygosity due to uniparental disomy or consanguinity. It will not detect truly balanced chromosomal rearrangements, low-level mosaicism, DNA sequence mutations that result in single gene disorders, or trinucleotide repeat expansion disorders such as Fragile X syndrome. So let's talk about the workup of neurodevelopmental disorders in the pre-exome era. Now, there are separate practice parameters for intellectual disability, for autism spectrum disorder, and also for cerebral palsy. What I've done here is present a more unified approach to the workup of a child with a neurodevelopmental disorder, whether that's ID and or autism and or CP. Note that this approach is going to be different whether you consider when you consider exome sequencing, which I'll discuss in part 2 of my talk. So the first step is asking, does the child have CP with a normal IQ? If the answer is yes, then make sure you get a brain MRI and then ask yourself these questions. Does the presumed cause of CP match with the child's motor and cognitive presentation? For example, is this the 32-weeker who has spastic diplegia with PVL on their MRI? Is the clinical course non-progressive, i.e. a static encephalopathy? Is the MRI abnormal in a way that explains the child's presentation? Meaning, for example, perinatal stroke in a child with hemiplegia. If any of the answers are no, meaning that there is a red flag, then we refer to neurogenetics. If all of the answers are yes, meaning that there are no red flags, everything is consistent, then continue expected management. So if the child does not have CP, then we go on to step 2. So step 2 is asking yourself the question, does the child have intellectual disability or autism? The answer is yes. Form a detailed history and physical with the following in mind. Clinical history involves getting a sense of the birth history. Are there any seizures? Asking good developmental history. How delayed are they? Is there any history of regression? Getting a family history. What other family members are affected? Performing a general exam, focusing on dysmorphisms, eye findings, cardiac abnormalities, organomegaly, skin findings. performing a detailed neurological exam, looking for nystagmus, hypotonia, spasticity, other tone abnormalities, abnormal reflexes, ataxia, focal findings, and then looking at ancillary studies like hearing and vision testing. If you can't establish a diagnosis or do not suspect a diagnosis, we go on to step 3. If the answer if the answer to the question of does the child have ID or autism is no, then genetic testing, of course, is not warranted. So let's go on to step 3. So step 3 involves asking the question, is there any evidence of metabolic or mitochondrial dysfunction? Symptoms include things like cyclical vomiting, developmental regression associated with illness and fever. Multi-system involvement can be evident with dermatological changes, gastroparesis, cardiac, liver, kidney problems. Metabolic or mitochondrial dysfunction can be evident on labs such as acid-base or electrolyte disturbances, anemia with elevated MCV, lactic acidosis, unclear or unknown newborn screen results. If there is evidence of metabolic or mitochondrial dysfunction, then we refer to neurogenetics and stop. If there isn't, then we go on to step 4. So in terms of step 4, for all patients, send microarray and then Fragile X trinucleotide repeat expansion analysis, except if the patient is female and has autism and has a normal IQ. Let's say you do this first tier workup and you can't establish a diagnosis, then you go on to step 5. So for step 5, this is the second tier workup. So for females with either autism or moderate to severe ID, consider MECP2 sequencing. For children with autism and macrocephaly, you consider P10 sequencing. You send a brain MRI if it's clinically indicated. For example, if there's micro or macrocephaly, seizures, regression, a history of coma or encephalopathy. You consider an EEG if there are suspected seizures, if there's loss of social communication functioning, specifically regression in these language areas. If you can't establish a diagnosis at this point, you refer to neurogenetics and stop. So what is the rationale for these recommendations? CMA was previously recommended as the first-line test in the initial evaluation of individuals with ID, autism, and multiple congenital anomalies. It has a diagnostic yield of 15 to 20% in the cases of unexplained ID, autism, or major congenital anomalies, which is higher than the diagnostic yields for these other studies that are shown in the graph. It changes medical management. These are studies showing that 35 to 55% of patients with an abnormal CMA result underwent some sort of management change due to their diagnosis. Meanwhile, Fragile X and Rett syndrome testing have a diagnostic yield of about 2% each in cases of intellectual disability. The yield of Fragile X testing, Rett syndrome testing, and P10 testing is as high as about 5% in cases of autism. Screening for inborn errors of metabolism in children with ID has a yield of between 0.2% and 4.6%, depending on the presence of clinical indicators. Current guidelines don't really endorse routine metabolic screening in the absence of clinical indicators or red flags. Metabolic testing has what we call a low yield but high impact. This means that though the diagnostic yield is low, early detection and treatment can help prevent severe neurocognitive sequelae. Treatable ID is a great online resource that lists all the various metabolic disorders that can present with intellectual disability that have potential metabolic treatments. And it's a good resource in general. So far with these technologies, we've made a lot of headway in the diagnosis of neurodevelopmental disorders. So what's next? And this is part 2 of my talk. So basically welcoming the genomic era. There are literally thousands of genes where mutations will lead to recognized disorders, as you can see from this OMIM report. The vast majority of these mutations affect, are thought to affect, coding regions of genes known as exons. The exome refers to the entire set of exons in the genome. It accounts for only 1% of the genome, like a slice from an apple. Traditionally, identifying such mutations required sequencing one gene at a time, so-called Sanger sequencing. The problem with this approach is that single gene disorders can have very heterogeneous presentations, and patient presentations may fit with not just one, but several genetic disorders, different genetic disorders. So you could sequence one gene after another, but this gets expensive very quickly. So what's the alternative? Enter whole exome sequencing. So I won't spend too much time on the specifics, but the basic concept involves taking a patient's DNA, shearing it, using baits to specifically target exon regions, washing out everything else, sequencing all of those regions, and then using powerful computational techniques to put all the data together and analyze all the variants. There are a couple of key advantages of whole exome sequencing or exome sequencing. It's about $5,000 to $9,000, which is relatively inexpensive compared to single gene sequencing, which alone can cost several thousands of dollars. Importantly, it offers a way to screen confusing patients. So what I mean by that is patients who may have atypical presentations of a disease or who may have early presentations of a disorder where the classic findings haven't yet appeared, or who may not have one but two or more genetic disorders. Of course, there are certain limitations to whole exome sequencing. Not all exons are captured, and some may be captured not as well. Some mutation types are not detectable, so these include trinucleotide repeat expansion disorders like Fragile X, exon level deletions or duplications, certain size chromosomal deletions or duplications, balance rearrangements, and intronic or non-coding variants. Finally, exome sequencing is limited by our knowledge of the unknown. So basically, genes whose functions are not well characterized, or genes which lack a solid association with disorders, or the case of variants of unknown significance, meaning you have a misspelling in a gene, but you don't know how to fully interpret that misspelling. As a result, interpreting results of exome sequencing really needs clinician input to determine if a result is a pathogenic or a variant, meaning it's a misspelling in a gene that's been previously reported and that explains the patient's presentation. If it's a likely pathogenic variant, if it's a variant of unknown significance, a misspelling in a gene, and you're not quite sure if it's deleterious to the protein or not, if it's a likely benign variant or if it's a benign variant. So needless to say, it can get pretty tricky at times, so genetic counseling is really important to this whole process. So this is a test that pediatricians should not routinely be ordering, but it's something that should be known and discussed. So what's the diagnostic yield of exome sequencing for the neurodevelopmental disability population? This is a study that we published a few years ago that looked into exome sequencing for the NDD population. 78 patients were included in the study. These patients presented for etiological evaluation of previously unexplained neurodevelopmental disorders. These disorders included developmental delay, intellectual disability, CP-like motor encephalopathies, autism spectrum disorder, so a heterogeneous population. Our overall diagnostic yield was 41%, or 32 out of 78 patients. So this means that 40% of patients who underwent exome sequencing in the neurogenetics clinic had a change in a gene that was causative of their clinical presentation. This yield is much higher than other forms of genetic testing, including chromosomal microarray, which is only 15 to 20% for this population. I think this table is really important. So for every patient with a presumptive diagnosis by exome sequencing, the diagnosis changed management in some way. For example, it influenced reproductive planning, resulted in medication changes, and so on. And I have the list over here, and you can go through in detail. There have been a number of exome sequencing studies like this since we published this in 2014. This past year, last year I should say, Dr. Sahin from our institution, Dr. Miller from our institution as well, led a group of people to see what is the overall diagnostic yield of exome sequencing for the NDD population. We did a meta-analysis of the literature on studies that examine the diagnostic yield of exome sequencing for intellectual disability and/or autism. The yield of exome sequencing was 36% overall, 31% for isolated NDD, so patients who presented with ID and/or autism but no other specific features, and 53% for the NDD plus associated conditions, so patients who presented with ID and/or autism but had additional specific features such as microcephaly. So just by diagnostic yield alone, comparing the diagnostic yield of exome sequencing for the NDD population, the diagnostic yield of exome sequencing is much higher than that of chromosomal microarray, 36% versus 15 to 20%. So this brings us to the workup of NDD, of neurodevelopmental disorders, in a post-exome sequencing era. So what we proposed, based on this meta-analysis showing that exome sequencing has a much higher diagnostic yield than chromosomal microarray for the NDD population. So what we've proposed is suggesting exome sequencing as a first-line approach for the workup of children with neurodevelopmental disorders. So in this flowchart, you'll see here, so if you have a patient with intellectual disability and/or autism, with or without syndromic presentation, we suggest doing exome sequencing as a first-tier test, plus or minus copy number variant analysis. If you come up with a diagnosis, then you stop your workup. However, if you don't come up with a diagnosis, or you have an incomplete diagnosis, meaning you have a partial explanation for the patient's presentation based on exome sequencing findings, then the next step is to consider a chromosomal microarray. And if you arrive at a diagnosis, you stop. And if you still don't have an answer, then you can consider further etiological investigations. Often in the case of a non-diagnostic exome, in a patient who's had a non-diagnostic exome, who's had a non-diagnostic chromosomal microarray, what you can consider is reevaluating the exome sequencing data every 1 to 3 years. And the reason is that there's always updated information on new genes and the linking of known genes to novel presentations of disease. There's always new data and new knowledge that's being put out, and that will help interpretation of the exome sequencing data. So let's talk about some cases diagnosed by exome sequencing. The first is a 12-year-old boy with motor delay and spasticity from an early age. He developed progressive weakness. His IQ is normal. His parents were first cousins. His clinical course had been defined or labeled as CP due to HIE, or hypoxic ischemic encephalopathy, even though there is no suggestive birth history. He underwent an extensive workup, denoted here. His chromosomal microarray showed 8% homozygosity. Finally, he underwent whole exome sequencing, and he was found to have a homozygous nonsense mutation in ALS2. So this gene is responsible for infantile onset ascending hereditary spastic paralysis. This is a rare disorder characterized by progressive weakness and stiffness. The disorder damages motor neurons. Initial symptoms usually occur within the first 2 years of life. There's eventual paralysis of the legs. There are some key points about this case. First, it changed expectations completely. This was not a static condition. Rather, this was a progressive condition with progressive motor deterioration. It also enabled appropriate recurrence risk counseling and genetic counseling for siblings. Another key point is that it highlighted that there are neurogenetic masqueraders of CP. A diagnosis of CP without suggestive birth or perinatal history should raise red flags. Finally, when there are many candidate genes under consideration, for example, there was 8% homozygosity on the chromosomal microarray, exome sequencing can be a cost-effective approach to dealing with all of these different possibilities at once. Case 2 is also interesting. So this is a 3-year-old girl with global developmental delay. She also had low muscle tone, small head, polymicrogyria, and cortical brain malformation. She had polymicrogyria and microcephaly. She underwent extensive genetic and metabolic workup, and all of these results were normal. And on exome sequencing, she has a de novo heterozygous mutation in a gene called DYNC1H1. At that point, this was a newly described gene. Mutations in this gene have been associated, since then with severe intellectual disability and neuronal migration defects consistent with our patient's presentation. This gene encodes adenine, which belongs to a group of molecules that acts as molecular motors. Interestingly, mutations along this gene have also been implicated in Charcot-Marie-Tooth, which is a genetic peripheral neuropathy, and they've also been implicated in SMA, spinal muscular atrophy. So indeed, because of this knowledge, she underwent EMG nerve conduction study, and this showed findings that consistent with mild SMA. Her prognosis changed since we now know that she has progressive motor disorder. Some lessons from her case. Since this was a newly described gene at that time, clinical testing for this gene was not available. Plus, diagnosing really rare disorders like hers expands the phenotype associated with these disorders. Here's the third and final case. So she's a 4-year-old girl with global delay and failure to thrive. Her early motor milestones were normal but slowed when she was 1 year old. She's had progressive motor difficulties. She developed dystonia and epistatonus, swallowing difficulties, and staring spells. Her initial MRI close to 2 years of age was normal, and repeat MRI when she was 3 years old showed these subtle bilateral signal abnormalities on T2 FLAIR imaging. Workup in her, again, was extensive and was normal. She underwent whole exome sequencing, which identified a homozygous mutation in PANK2, which can cause PCAN, or pantothenate kinase-associated neurodegeneration. PCAN is a disorder of iron accumulation in the brain. There is progressive deterioration in motor function and cognition. The classic finding on MRI is the eye of the tiger sign, which is thought to occur in all cases of PCAN. Our patient did not develop this sign yet when she had her MRIs. Knowing the diagnosis had key implications, we identified the diagnosis before the typical MRI changes occurred. In general, making a diagnosis earlier may be useful for clinical trial evaluation and other treatment options. In her case, there's a trial available for an iron binding agent. The main takeaway point from this case is that exome sequencing can facilitate a diagnosis earlier, which can shorten the diagnostic odyssey, which can sometimes take months or even years or longer. So let me wrap things up with some conclusions and future directions. All patients with unexplained neurodevelopmental disorders deserve workup. Etiological diagnosis can improve management and have benefits for the patient and family. Rapid technological advances are improving our ability to identify underlying cause of neurodevelopmental disorders. The high diagnostic yield of exome sequencing supports the use of this technology in pediatric neurology practices, and genetic counseling throughout this process is absolutely indispensable. Thank you.